The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Dawn Miller with the Healthcare Authority, and I am pleased to have with us today Jessica Blows, who's going to talk to us about medication-assisted treatment. We're going to have a little bit different scenario today in that the webinar is recorded, as it always is, and so I will send out recording to this to those to everyone, to those of you who are attending, as well as those who registered that cannot. But we're going to have two different people talking today. One is Jessica, and later on, one is a colleague of mine who's going to share some information about a grant that's upcoming. So having said that, I am going to bring up the slides so that you can see them. And I'm going to ask that someone let me know in the chat box that you can, in fact, see them, just to make sure that we've got things working the way that it should be. Can folks see the slideshow? And go ahead and by all means put in the chat box or raise your hand or whatever you might want to do to indicate that's the case. Okay, I see. Looks good. Thanks, Lori. All right. So, Jessica, I'm going to turn it over to you.
Sure. Can you hear me okay, Dawn?
Absolutely, I can. And I believe probably the rest of the folks can too, since I can.
Awesome. All right, everybody. So thank you so much today for having me be a guest speaker on this webinar series. I am calling back from Washington from the lovely state of Rhode Island, where I'm traveling for work. So it's really good to be talking with a bunch of people from Washington as well this morning. Hope everyone's having a great day. So today's topic that I have been asked to speak about is the direct relationship between medications for the treatment of opiate use disorder and its intersection with employment rights. And again, I know that this is an important topic to discuss with individuals who are employment recovery support specialists and advocates for our individuals who are in recovery. But one thing I'd like to make as a quick disclaimer at the onset of this, and I'll probably repeat throughout the presentation, while this presentation today is primarily focusing on medications specifically for opiate use disorder, a lot of what I'll be talking about today is also going to be pertinent for individuals who might be taking medications for the treatment of other substance use disorders and mental health disorders. So a lot of the things I'll be talking about are basic concepts around client discrimination, client rights, and really a lot of them should be pertinent to any type of medication. And then Dawn will be running the slides for me since I'm remote. So please, the next slide, Dawn.
One of the things that I found, Jessica, and it appears to be the case today, is there's sometimes a bit of a delay. There we go, in getting the slides to advance.
Oh, sure, no problem. Okay, so actually, again, my name is Jessica Blows. I'm the Washington State Opioid Treatment Authority for Washington State. I work at Washington State Healthcare Authority. And really my title, and no, it sounds like a big scary title, but really what it is a position that allows me to assist with the treatment of any individual in our state who has opiate use disorder, who is getting treatment with an opioid medication. And we'll be talking more about what that means later, but that is my role at this time. And then also, would you, next slide, please. And then we'll also be talking about a couple learning objectives today. So at the end of this presentation, I'll want to have everyone have an understanding of what are the medications that are used for the treatment of opiate use disorder, how to understand basic employment rights for any client who might be taking a medication, again, for the treatment of their opiate use disorder, understanding recommendations for strategies that employers can take to promote a recovery-friendly workplace, and understanding who you can contact if you have a client that you feel is being discriminated against by an employer based strictly on the fact that they are taking a medication, again, for the treatment of their opiate use disorder, But again, as a quick disclaimer, a lot of this will be pertinent to any clients taking any type of medication for any behavioral health diagnosis. And then next slide, please. Okay, so oftentimes when we're talking about medications, you'll hear a lot of terminology. You know, in healthcare, we all love acronyms. This is no different. One of the most common acronyms you might be hearing about is this acronym MAT. So you might wonder, what exactly does MAT refer to? So as per SAMHSA, MAT stands for Medication Assisted Treatment, and this is the treatment of FDA-approved medications in combination with counseling and behavioral therapies in order to provide a whole person approach to the treatment of an individual with a substance use disorder. So a lot of people, for them, again, MAT can be inclusive of medications for opiate use disorder. A lot of people don't realize there are also medications for other substance use disorders. It could be some medications that have been approved for the treatment of alcohol use disorder, tobacco cessation medications, and hopefully in the future, with more research and development, we'll also potentially have medications that can be more beneficial for other substance use diagnoses like stimulant use disorder. And then again, in some ways, if you think about, again, behavioral health and mental health care, even offering mental health medications for the treatment of mental health, in some ways, psychiatric medications are like the MAT for mental health medications, or I'm sorry, mental health disorders. And then next slide, please. So again, since many individuals on this webinar may be working with behavioral health agencies, there's a couple of facts I'd like to go over around medications that'd be really helpful for everyone to know. So Washington state law and federal law no longer require that individuals who take medications for the treatment of opiate use disorders, it's no longer required that in order to give that medication, you have to take substance use counseling or behavioral health counseling. That was the law several years ago where counseling was required, but now there's a lot of evidence that shows that even if an individual is not able, for whatever reason, or willing to take counseling, there is so much benefit from them being able to have access to the medications that they should be able to take medications regardless of the fact if they're going to be going for counseling or not. So I just wanted to highlight that because it's very important depending on the setting you might be working in. Again, if you're working in a behavioral health agency, chances are 100% of your clients there who are taking these medications will also be receiving counseling. But say you're working as an advocate or, again, some type of recovery support specialist in a setting that is outside of a behavioral health agency, such as a primary care setting or a low barrier setting, you might be working with clients from different treatment settings that have a variety of different individualized goals and that they may not necessarily be going to counseling. And then that's okay, and that is legal. And then next slide, please. Oops, and I'm sorry, next slide, please.
And it's deciding to be slow. So this is one of those circumstances where it's decided that it's not going to respond when I ask it. There we go.
There we go. Okay, cool. Thank you. So we're going to be talking about what are the different medications that are used for the treatment of opiate use disorder. We have the first medication that is noted. It is an FDA-approved medication. It's methadone. This is one of the medications that has been out the longest. This is considered a full agonist medication. Individuals receive this medication only at specialty regulated clinics called opiate treatment programs, where individuals will go to these facilities and you actually obtain your medication being either administered to you or dispensed to take home at these facilities. And again, you cannot get these medications at a local pharmacy, and they're considered a Schedule II controlled substance. But these medications, again, as a full agonist, will block all withdrawal and craving symptoms in an individual with opiate use disorder. One thing that methadone will not do is it will not block the effects if an individual utilizes another opioid on top of it or another type of, So what this means is if an individual were to relapse while taking methadone, hypothetically, they could have a higher overdose potential than some of the other medications. So the second medication is buprenorphine products. So there's different types of products that have buprenorphine. Commonly, there's Suboxone, which is buprenorphine that's combined with naltrexone, and then Subutex, which is also indicated usually for individuals who are allergic to the naltrexone that's in the combined product, and it's usually indicated also for the treatment of pregnant individuals, and that is in the form of Subutex, and that is straight buprenorphine. So this medication is a partial opiate agonist, and again, it also, like methadone, will block the cravings and withdrawal symptoms that an individual with opiate use disorder is experiencing. This is a medication that is considered a Schedule III controlled substance, so it is able to be prescribed by any prescriber. So in our state, it's anyone who's an MD, a DO, an ARNP, or a PA in the state of Washington that also has a Data 2000 waiver from the federal government that allows them to prescribe this medication specifically for opiate use disorder, or this medication can also be offered at an opiate treatment program. And then if this product is combined with naltrexone, as is found in the generic of Suboxone, and individuals take this medication, the naltrexone in the combined product actually can help prevent high overdose potential if an individual happens to relapse while they're taking this medication, because the naltrexone in it will help stop any additional opiates from being absorbed basically into the body through the brain receptors, and then will decrease the likelihood that the brain will be so overloaded in its receptors that it goes to an overdose. And then the third option that we'll be talking about is naltrexone. So naltrexone is not considered a scheduled drug. It's not considered a controlled substance. It operates differently than the other two. It is considered an antagonist medication. So what this medication will do is if an individual is taking this medication and they try to take another opioid through a relapse or a slip up, they will not be able to actually, again, their brain will not be able to take in the medication. It actually will kick the body into a form of withdrawal and blocks the individual from getting the medication. But one thing this won't necessarily do is it will not necessarily help with craving symptomology and withdrawal symptoms as much as the other two medications, because it is a different class of drug. And this medication is only as effective while it's in the body of the individual. And if the individual stops taking naltrexone, which is most commonly given through injectable form, then they will have no benefit from that medication.
Okay, Jessica,
and then I know there might be a lot of...
I see a question. It says, can you mention who is allowed to prescribe methadone? Similar to how you mentioned who could for you. Sorry about that.
Sure.
For a moment, I
Definitely.
couldn't pronounce that word.
Yeah, great question. So again, for methadone, it is allowed to be prescribed and administered only in a specialty regulated behavioral health clinic called an opiate treatment program. It can only be offered for opiate use disorder. Again, in these clinics, they employ usually a medical director that is an MD or a DO. They usually employ other medical doctors and physicians who work under them. They can apply for exceptions from the federal government to allow ARNPs and PAs to make independent dosing decisions. And then they have nursing staff that actually provide the medication to the clients. But again, this medication can only be offered under the umbrella of an opiate treatment program. If you take that same doctor and you put them out in a primary care clinic or another behavioral health agency, it is not legal for anyone to provide methadone. Oddly enough, technically, methadone is available for most doctors for the treatment of pain, but the Federal Controlled Substances Act from decades ago has said you cannot treat opiate use disorder with an opioid medication, and we have built an entire system around waivers and exceptions to this federal rule instead of the federal government just changing it. We could spend a whole webinar talking about why that is, but at this time, again, these medications really are only able to be offered usually by either specially trained individuals in the case of buprenorphine products or in specialty regulated clinics for opiate treatment programs. So I know it's a long answer. If anyone has questions, you can definitely contact me after the webinar. I have lots of other information that I could send out.
Wonderful. Thank you.
Thanks. And next slide. Okay, and then we're just going to talk about some of the stigma around these medications, because these are things you are going to be often coming across for individuals who are getting treatment for opiate use disorder. And it's good to know what is the truth and what are the myths, and how you can help combat stigma and misinformation. So one of the most common stigmatic things are, these medications are just trading one addiction for another. So again, that is definitely false. We're not just trading one drug for another. These are approved medications that are able to address the biological and psychological impacts of addiction. Again, they are meant for the treatment of some of the criteria for opiate use disorder, which includes controlling specifically withdrawal symptomology and as well as craving symptomology. And really, we have medications that treat physical things for other types of chronic illnesses. There are medications that help people insulin issues for diabetes. We have medications that help impact things with lung functioning for individuals with COPD. We have medications that affect high blood pressure. We have medications that we use for the treatment of hypertension. Really, these medications, we want them to be thinking of these medications in the same way. And again, we oftentimes don't hear these same discussions and concerns around medications for individuals who have mental health diagnosis. Some people with depression might take antidepressants. Some individuals won't take an antidepressant. Some people might take one antidepressant and then switch to another antidepressant. Some people might go on and off for a number of years. And we don't usually have these discussions saying like, well, this person's not really in recovery for their depression. And what we really want to get to is a point where these medications are thought of in the same way for substance use disorder. Another one of the myths is that these medications are really only meant for short-term use. So that is another myth. There is actually no evidence that has been found that demonstrates that there really is any benefit for a client having to discontinue these medications. And now the recommended course of treatment is that clients should be allowed to stay on these medications for as long as they feel they are receiving a benefit from them. And really, it should be both a decision that's being made between a patient and their physician doctor, as well as an individualized patient treatment decision. The next one is that, well, maybe my patient's condition might not be severe enough for them to have these medications. Maybe they've had opiate use disorder for a little while, but I don't know if they really need to take these medications. Again, this is a falsehood. These medications can help individuals at any point in their journey to recovery. And again, there's all different types of medications, the agonists, full agonist, partial agonist, and antagonist medications. And individuals should have the ability to switch between medications if one isn't working well to try and find the best fit for them. And because of this flexibility, individuals, again, could take it at any different point. And then we'll go to the next slide. So another myth is that taking these medications will increase the risk of overdose in clients. So again, I know we talked about some of the properties of the drugs, and that, again, especially for methadone, if you use on top of it, it can actually increase the likelihood of you having an overdose. However, numerous studies have shown that the time period where most individuals overdose is after they have gone into an extended time period of withdrawal, and then they have a relapse. Because again, if an individual is in withdrawal, whether because they're at a withdrawal management detox facility, or they've just been able to stop using on their own in their home environment, Your tolerance to the drug will drop. If you have a slip up and you relapse, you're more likely to die. Individuals, though, again, who are taking naltrexone are protected by the blocking properties of that drug. And then individuals who are taking methadone and then buprenorphine, because these medications are chemically similar to other types of opioids, they actually keep a small level of tolerance in the body, which is a protective factor if an individual does relapse, because then they will not be more likely to overdose. Another myth is that providing these medications will only, again, disrupt and hinder a patient's recovery process. Again, that's definitely not true. These medications only really ever in research been shown to assist patients with their recovery and improving their quality of life. And again, it does help reduce overdose death rates. And there's a lot of evidence that actually shows you can decrease the likelihood of overdose by over 50% if someone is on one of the agonist medications, and that's huge. And then the last part is that, there isn't any proof out there that medication is better than an abstinence form for opiate use disorder specifically. And again, that is not accurate. This is now considered by all national associations as a first-line approach to treatment. All clients should be informed about these medications and given a choice and coordination to obtain these medications if they so choose. And then this is something, again, that has been promoted by the American Academy of Addiction Psychiatry, the American Medical Association, the National Institute of Drug Abuse, SAMHSA, the Substance Abuse and Mental Health Services Administration, the National Institute on Alcohol Abuse and Alcoholism, the CDC, Center of Disease Control, as well as us here in Washington State. The evidence is clear. These medications work for a great majority of our clients. And again, we do believe in client choice. So if the client does not want to take these medications, that recovery journey should be promoted. But just like everything else, we want people and our clients to have informed decision-making. So it's not really informed decision-making unless we're letting people know about all the options for their potential recovery. And then I guess we will go on to the next slide. Okay, again, this is a wrap up. These medications are evidence-based treatments. Again, we're not saying that these medications are a replacement for other types of treatment needs, including counseling and or recovery support services. Having these medications does allow individuals to have patient choice present in their treatment, to again have individualized treatment decisions. And then these medications also can help address physiological changes in the brain with the chronic brain disease model. The two medications, methadone and buprenorphine, again, can allow a stable amount of, again, opiate-like substance in the brain that allows the brain to recover much better than if an individual is rapidly cycling through relapse and then abstinence, which puts a lot of stress on the brain, going back and forth, taking drugs one day, taking drugs a lot the next day, maybe not having anything the third day. And again, if you're able to have either complete abstinence with naltrexone or that small minimal amount that keeps things level in the brain for buprenorphine and methadone, it will allow a brain to recover. And as we all know, addiction is a brain disease, but all individuals can recover. So then we'll go into the next slide and get into employment. Oh gosh, I'm so sorry. I guess one more thing before we get directly into employment. I was asked to include this on a slide because oftentimes some individuals might have concerns working with these clients about if we're trying to help them get employment and support them with employment. Well, what do these clients actually look like? Well, people know on their face that an individual is taking these medications. So if an individual is on a clinically appropriate amount of methadone or buprenorphine and they have been medically stabilized, meaning their doctor has found an amount that works right for them, that client should not have any withdrawal or craving symptomology happening for opiate use disorder. So they shouldn't have, a feeling like they might feel nauseous, their mucous membranes won't be running, their eyes won't be watering, and they won't be having to go to the bathroom. all the withdrawal symptoms that accompany opiate use disorder. But also, if you're on an appropriate dose of medication for yourself, you should not be exhibiting any symptoms of over-medication. And that would be appearing sedated, nodding out, again, pupil dilation that's inappropriate, all those symptoms, and sometimes, again, that go along with the bad stigma that if you take one of these medications, you're going to look like you're impaired. So again, if you are receiving the right amount of medication for yourself, you should not be exhibiting any of those symptoms. And then again, if you have a client you're working with, though, who is taking these medications, and you notice they do have symptomology that's indicative of either continued withdrawal symptoms or a sense of over-medication, then what these clients really need is ongoing care coordination between themselves and their medical staff and their recovery support services team to make sure the client is getting medication adjustments from their medical provider so that they are at a stable place. And again, we would really want all recovery support specialists to help treat clients in a manner similar to how care coordination would need to be dealt with for any other type of medical complication that a client was receiving or having. Okay, and then we can go on to the next slide. Okay, so now we're going to get into, with that foundational knowledge, we're going to get into the topic you are all here most interested in today, client employment rights. So one of the most important things to note about this, again, is that above state law, we have federal laws in our country that protect individuals who take medications for opiate use disorder against job discrimination. And then again, a lot of what we're going to be talking about is still going to be pertinent really for any medication for the treatment of any behavioral health disorder. So everyone has probably heard about the ADA, the Americans with Disabilities Act, and then the lesser known Rehabilitation Act. Both of these federal laws prohibit most employers from firing, refusing to hire, or discriminating in the terms and conditions of employment for any qualified job applicant or an employee strictly on the basis that they have a disability. And you might be wondering, well, is this considered a disability? But many courts in our country have already ruled and set legal precedent that individuals who have substance use disorders and anyone that is taking a medication for this disability, and specifically for opiate use disorder, is considered a disability, and therefore they are protected from discrimination by both the ADA and the Rehabilitation Act. And then we can go to the next slide. So again, here's some information about the types of employers that are covered under federal laws. So the ADA does apply to all state and government-led employees, as well as any private employer that happens to have 15 or more employees. If your client is going to work at a place that is less than 15 people, then later on in the presentation, we have some information on different legal sources you could reach out to. You would have to refer clients to reach out to them because the ADA may not apply. But then also the Rehabilitation Act applies to all federal employers and all public and private employers who have received any type of federal grant money, contract money, or aid. So this could be anyone, again, that's participating with a grant, any types of federal funding, Medicaid funding. So on its surface, it might not sound like a lot, but if you start thinking about all the places that federal money touches, the Rehabilitation Act actually covers a lot of different employers. You can go to the next slide. And then again, these two acts talk about, in general, they cover different employers. And what, again, they talk about is you may not, as an employer, deny a job or fire a person simply because they are in treatment for SUD and or taking a medication for the treatment of their mental health or behavioral health medication, including opiate use disorder meds. Also, all of these employers must provide quote unquote reasonable accommodations when needed to enable an individual with a disability to perform all their job duties unless this would cause an employer demonstrated undue hardship. And we'll talk more about what that means. We can go to the next slide. So again, oftentimes there's a question of what actually are we talking about when we say reasonable accommodation. So reasonable accommodation is really any change in the work environment or in the way things are customarily done that would enable an individual with a disability to enjoy equal employment opportunities. So reasonable accommodation examples could be job restructuring, part-time or modified work schedule needs, permitting a leave of absence, and then being able to be reassigned to a vacant position if they're demoted strictly on the position of the fact that they have a problem. And we can go to the next slide. So again, an employer under these two federal laws is not required to grant an accommodation that would cause quote unquote undue hardship, which means if it's going to result in a significant difficulty or expense. In this case, employers are able to suggest alternative accommodations to the one proposed by the employee or job applicant. And sometimes that might be an alternative proposal that's amenable to the client. And then other times, sometimes it's something that's not amenable. And in that case, again, later on when we talk about referrals for legal recourse for your clients, that would be a time to refer clients to legal counsel. And we'll go to the next slide. So we wanted to provide a quick case example about these concepts we just talked about. So we're going to have a case example of an individual. We're going to say her name is Kira. She is a client that's receiving treatment at a methadone clinic. She also works at a hospital from 2 p.m. to 10 p.m. And again, she's been receiving methadone for the treatment of her opiate use disorder for 1 year. The program, the opioid treatment program, requires the client Kira to come and pick up her dose of medication 3 times a week. It only happens to be open between 7 a.m. and 2 p.m. But unfortunately, Kira's employer, the hospital, has changed her shift so that she has to work from 7 a.m. to 3 p.m. every day. So the question is Kira entitled to a reasonable accommodation, changing their former shift in order for her to be able to continue to have her employment and continue to receive her medication? We'll go to the next slide. So in this case, the answer would be yes. Unless the hospital can demonstrate an undue hardship, allowing a schedule change so Kira is able to continue to pick up her dose, that would be considered a reasonable accommodation, and legally her employer should allow her to do so. And again, it's very hard to demonstrate as an employer that they are experiencing undue hardship if the requests are, again, usable, but also if they claim an undue hardship, a client is able to work with the employer to find an alternative accommodation. And then again, if that is still not amenable to the client, then also the client has legal recourse to make a complaint about the employer and possibly file legal counsel with them. And we'll go to the next slide. So another common question that comes up is around medical inquiries and examinations and drug tests. So as we all know, lots of employers will drug test clients or ask questions, invasive questions, if anyone has any past history of drug use. So under federal law, a drug test for employment is not considered a quote-unquote medical examination. Therefore, drug tests are legally allowed to be administered at any time if all applicants and employees in a job category are required to be tested for that job. And then again, there are different tests that different individuals will take, but there are certain drug tests that will detect if an individual is taking methadone or a buprenorphine product. And there might be some other drug tests that won't go into that level of detail, but may demonstrate that a client, it might just show up with a generic thing saying that a client is taking opioids because these are considered a form of opioids, or again, a drug test might not detect those medications at all. We can go to the next slide. So what happens though if these clients are taking these medications and they have a drug test where the medications are detected? Again, employers at that point, if a client does have to make a choice to self-disclose if they want to reveal that they're a person in recovery and that these medications are part of their recovery treatment, and at that point, employers are legally allowed to ask the individual if they can provide documentation demonstrating that they're taking prescribed medications for the treatment of their opiate use disorder. And again, acceptable documentation could be something as simple as a letter from their opiate treatment program or a letter from their doctor confirming that they're taking a prescribed medication as part of their treatment. However, and this is unfortunate, but this is the legal precedent at this time, if an applicant or employee does not feel comfortable and does not want to provide documentation, or they want to not report that they are taking medication or participating in a treatment program providing them medication, they have every right to do so. However, without that information, it is legal for an employer then to deny the person a position that they are applying for and or to take negative actions up to leading to firing an individual. So again, it would be good for individuals who are in recovery, who are taking these medications, to be informed about this so they're able to talk through with their support system and their recovery support team, their counseling staff and their medical staff, how to have these types of conversations with potential employers in case drug testing does come up. And then again, everyone is entitled to not report their substance use history to an employer, but also then unfortunately, legally in the eyes of the law, if you aren't able to disclose that you have a disability, then your employer is able to fire you. So again, not something I'm very happy about, but that is the federal law at this time. And then we can go to the next slide. So another question that might come up is medical leave. Oftentimes, you know, an individual might already be working for an employer and perhaps they're looking to enter into recovery for the first time, and they may have to take some medical leave. Or again, it could be someone who's been in treatment for a while and has been employed, but then potentially has a relapse or really wants to prioritize their ongoing recovery and need to go back to treatment. So both the ADA and the Rehabilitation Act, as well as another federal act called the Family and Medical Leave Act, the FMLA, which is again something many of you heard of, all three of these give employees the right to take medical leave, which includes treatment for substance use disorders in certain circumstances. However, it is also worth noting that it is illegal discrimination for an employer to deny someone a medical leave, specifically because the treatment that they are searching for is involving treatment for opiate use disorder, or because the treatment that they are looking to take would mean taking a medication for the treatment of their opiate use disorder or another mental health medication. And we can go to the next slide. So I know we just went over all kinds of stuff, and it's a lot of stuff to learn about. And you might be thinking of way more questions that you have about everything from employment. How do these things relate to housing, including recovery residences? How does this relate to discrimination and client rights about government activities, government benefits, government services? How this intersects the child welfare system, clients on probation, parole, zoning, issuance of driver's licenses? How does this also relate to private educational, healthcare, and other facilities that all meet ADA definitions of places that can have public accommodations? So those are all topics that we're not really talking about today, but I want to give you a really good resource of where you can look up some of this information on all of these topics. So next slide, please.
And I do see, Jessica, that there's a question from Lori. Great presentation. Is it possible to get a copy of the slides? I will be sending out a copy of the slides, and we'll also send out the recording of this. So if you want to listen to it again, you're able to. Or if you have a colleague that may want to hear it that hasn't been able to attend, they will have that availability also. So good question.
Yeah. Thank you.
Okay, and for whatever reason, it's decided to slow way down again as far as, there we go.
There we go. So all of the information I just talked about, believe it or not, as much as I would love everyone to think that I'm some kind of an expert on employment rights and legal things, I am only just a counselor. So all of the information I just went over actually came from this amazing resource guide that had been put out by the U.S. Department of Health and Human Services through SAMHSA. It is a document that has been out for at least 5 or 6 years. It's still all accurate. It's called Are You in Recovery from Alcohol or Drug Problems? Know Your Rights. The rights for an individual who's taking medication-assisted treatment. There is a link on here. Again, it sounds like I'm so happy this will be sent out. You can just copy and paste that SAMHSA link in order to find a way to download all this material, as well as you can also call SAMHSA's Health Information Hotline at the number there, available in English and Spanish. And this information, again, can be sent to you physically if you want some copies sent to your office or to give out to clients. And then the great thing about this is, again, this little manual talks about all of those other topics that were just on the previous slide and really covers client rights for individuals who are taking medications across a very extensive array of treatment milieus and different, basically places, again, your clients might be intersecting with, again, including recovery housing, legal system, and other types of healthcare rights. We'll go to the next slide. I wanted to take a couple minutes to talk about strategies for employers. So again, a lot of you are working for behavioral health agencies or other types of employers, or again, you might be asked in your role as an advocate, how can we create more recovery-friendly work environments? So these are some strategies that we are recommending employers to review. One would be they could reconsider how they're utilizing work-related drug tests. Again, helping employers get more informed about the fact that these medications now exist for the treatment of opiate use disorder, and that some individuals might test positive. And just because someone tests positive for methadone or buprenorphine doesn't necessarily mean that they are using illicit drugs. So again, education is empowerment. It talks about educating and empowering employees. Companies can choose to provide training and education to employees on things like opiate use disorder and other mental health issues, as well as encourage safe medication disposal of unused medications at their facilities, or have information up on like employee lunchroom boards about where to do so that way they can help protect themselves and their family members. And then again, making individuals more aware of treatment options, or having something like the Washington State Recovery Helpline up in a lunchroom. So again, if an individual who's working or their family member is having an issue with substance use disorder or mental health disorder, they can have information about how to get access to treatment. Supervisors at employers can receive training that will help them recognize the signs of abuse, and then knowing how to help refer employees to an EAP, an employee assistance program, or again, having a way to work with individuals who might be having an issue, and instead of just taking a negative action such as firing them or penalizing them, allowing them to take something like family medical leave to address treatment, or giving, again, individuals opportunities to seek treatment and be able to demonstrate that they are getting help instead of just firing them. And we'll go to the next slide. Another thing that can be done is, again, employers can implement robust access to high quality behavioral health services through things like employee assistance programs. It talks about stress, mental illness, substance use, and long-term post-surgical recovery can all contribute to individuals becoming dependent on prescription painkillers inadvertently. So employers should encourage employees to take advantage of things like EAP and medical plan benefits, their insurance that they're offering, to make sure those benefits that they're offering do pay for things like counseling, rehabilitation, and screening from individuals who can help monitor an employee's drug use and offer other resources to help individuals in their recovery journey. And then another thing that employers can consider doing is, in their insurance plans, buying plans that will cover or require alternative pain management options. So that would be making sure you have coverage for clients, coverage from your employees that could include pain management that's not opioids. So if someone is in a car accident or someone is recovering from like a C-section or other things, in addition to opioids, they can also have lifestyle adjustment, behavioral therapy, exercise, acupuncture, massage, chiropractic care. These types of strategies can help reduce an individual's pain without the risk associated with continuing to prescribe only high levels of opiate medication, and that considering reducing cost sharing on alternative pain management therapies for patients with a history of addiction or opiate abuse. So then that way, again, if someone is in recovery and they do have genuine pain issues that arise from either an injury in the workplace or again, some type of life circumstance like a car accident, they're able to receive other types of pain management other than just opioids, which could end up being, unfortunately, a triggering event for some individuals who are in recovery from painkillers and other types of opioids like heroin and fentanyl. Okay, next slide. Another thing employers can do is implement utilization management to encourage evidence-based safe prescribing of prescription opioids. Things like step therapies should require documentation of pain evaluations and documentation of non-opioid or generic treatments before moving to cover opioids. They could set quantity limits to reduce the likelihood that patients will abuse or overdose on drugs. For example, one private employer's insurance, Blue Cross Blue Shield of Massachusetts, requires a prior authorization for anyone who wants more than a 30-day supply of opiate medication in 2 months. And those are things that employers can help set up to help have protective factors around the treatment that may be offered to their employees, as well as they can consider implementing lock-in features, as what they're referred to, for high utilization users. So again, adverse event due to opiate addiction has a rise. Medicaid and a lot of commercial plans have begun to lock in an individual who might be suspected of overutilizing an opiate by requiring them to obtain all their medication at either a single pharmacy or a single prescriber specifically for prescription opioids. So in that way, it can help an individual who maybe isn't in recovery yet, but is really struggling with opioid use from being able to go from doctor to doctor and pharmacy to pharmacy to get lots of opioids, which could unfortunately increase their likelihood of overdose. And we'll go to the next slide. So we've been talking about all kinds of stuff, but I really want to wrap up today. Again, there could be incidents that come up that aren't covered by the topics we just talked about in the webinar. And really, you also need to know how to inform your clients about where to go if, again, they need really nuanced advice that, again, we are not often legal professionals. We may not have the ability to give them information, but how clients can be informed and, again, empowered to educate themselves and go to experts who can give them that information to make sure that their rights are happening. So the first part is, how do you get assistance for your client if you feel they are being discriminated or they feel they are being discriminated against by an employer? So the first thing they can do is they can always file a complaint with a federal or Washington state agency which is authorized to investigate and remedy violations of disability discrimination. So clients and their advocates do not need a lawyer to do this. And oftentimes filing a complaint can be faster and easier than a lawsuit, and sometimes will result in the same remedies. However, it's really important to note in this instance that there oftentimes can be different statutes of limitations for filing deadlines. And what that means is you might only have, as a client, a certain amount of time to file a complaint in order for it to be looked at by these entities. So it is important to encourage clients, if they're having issues with an employer, if they feel comfortable, to file a complaint as soon as possible so it increases the likelihood that it will be able to be looked at. And we'll go to the next slide. There's some other resources that, again, anyone who's downloading this later will be able to look at, and it'll be helpful to keep. So here in Washington State, we have a part of our state government, the Human Rights Commission. We are very fortunate that they have taken a great interest in particularly medications for opiate use disorder and then also behavioral health issues. Any of your clients or yourselves can contact the Human Rights Commission on behalf of the client to ask for more information about making a complaint against an employer who might be discriminating against them. There are also federal government agencies that are particularly involved with looking at these types of things. One is the Equal Employment Opportunity Commission, and they also have field offices across the U.S. You can find them at the website that is listed. And then also the U.S. Department of Justice has a civil rights division where you can file an ADA complaint for anyone that you feel is breaking and violating ADA. And again, that can be filled out anonymously or with a name at the link that is listed. And then we'll go to the next slide. And then lastly, basically, if there are some times you have done all the things you can, you've reached out, you've made a report. Ultimately, though, sometimes discrimination is happening. If your client needs information on how to pursue legal recourse, here's some information for you. So additionally, in most but not all cases of discrimination, usually individuals do have the ability to file a lawsuit in federal or state court, in addition to or instead of filing an administrative complaint with one of the agencies we just talked about. So again, it doesn't have to be an either or, but some clients may want to pursue one avenue or the other. Unfortunately, though, to pursue legal action, clients and their advocates would need a lawyer to do so. And again, however, noting that there's different statutes and limitations for filing deadlines, legal cases, and legal counsel for individuals should always be consulted. And things like Public Defenders Association would be a good resource to reach out to. And we have a couple other resources that are on the next page. These are some resources that are here in the state. Again, I just mentioned the Public Defenders Association, which I'm so sorry is not listed on here, but also there are other client rights groups that will reach out and work with clients, even if they may not have financial means to hire a lawyer. One is Disability Rights Washington. The other is the American Civil Liberties Union of Washington. And the other is the Northwest Justice Project. And all of those, and again, the Public Defenders Association would be really good resources for all of your clients about anytime they feel that legally they're being discriminated against. And then the next slide.
Jessica, I see a couple of other questions that I'm just going to mention before I advance. Kirsten has asked, what specifically is an overdose amount of methadone, particularly? Follow-up question, when dispensing this drug to an OUD client, what is the onboarding level? Pardon me.
Okay, so the second question about what is the onboarding level of the medication amount, that is going to be really dependent, again, on an individualized medical decision. Every body is different. Literally, everyone's body is different. So the same way you have different levels of medication that you might be prescribed for everything from antibiotics and behavioral health medications, it's the same thing for opiate use disorder. There are certain legal limitations and nuances that if you would like to know more about, I would encourage the questioner to contact me directly. But again, I guess the more generic answer is it's going to be different for everybody, so there's really not something I can easily answer. And then I'm so sorry, Dawn, would you mind repeating the first question?
Let's see here. And for whatever reason, of course, it's gone away. And I would ask Kirsten to go ahead and ask the question again.
Okay. And then
the other thing that I'm going to offer is that we're going to do things a little differently today than we have done with some webinars. Because of Jessica's time limitation with being, providing this long distance and actually in another activity. If there are additional questions, we are going to go ahead and have you send them to me via email. I will send them to Jessica. She will compile the answers, and then I will send it back out to the group. So it's going to be a little bit different than it has been for some of the webinars, just because of need to accommodate. All right.
Yeah. Thank you for your,
thank you. Sorry about that.
Everyone's recommendations for myself on this date. And then really we're just going to wrap up and say that, again, there's also national resources that are available even outside of the state. The Legal Action Center is the leading national entity supporting individuals' recovery rights if you have substance use disorders. They have a lot of great resources on their website that you could check out, and again, different information you could just print out in general for your clients, as well as ways for the clients to contact them if they have questions about obtaining actual legal counsel. But really, at this point, the last couple slides are really just talking about my citations for today, where you can find some more information. And then again, like Dawn said, I'm so sorry. I only had an hour today to participate with you all, but I really hope this information has been helpful to you, and I really do look forward to any questions that people have. I promise you, if you submit these questions to Dawn and this webinar, they will be compiling the questions, and I will be writing an FAQ form of a response to them. And then you can also go to probably the last slide, Dawn, it's 2 slides from now, and it will have all my contact information. So you can also always feel free to contact me at any time. This is my work email and then my desk phone number at work. I do travel quite a bit for work, so sometimes it might take me a day or two to get back to someone, but I will always get back to you. So really use these resources, and then, yeah, the thing I can only say is fight for our clients. We all know that they're worth it, and this is such a disenfranchised population that does experience so much discrimination, and really we need to have the resources and advocacy to push for what these people deserve. They are people, they have rights, and these rights need to be respected, even by employers. So
very well,
with that final round call, I always again want to thank everyone for letting me participate today, and I also appreciate everyone accommodating my schedule and allowing me to leave the webinar early.
Absolutely.
So thank you, everyone.
So much, Jessica. Very helpful information. I do see that Lisa's had her hand up, and I apologize for not getting to it sooner. Lisa, I've unmuted you. I don't know if you had something to say quickly to Jessica before she had to leave, or if it was something.
Yeah, Jessica. Yes, this is Lisa Bennett Perry. So Jessica, first I want to thank you for all this great information. These questions do come up regularly. One of the questions that I've always had is when a person goes in, comes to an employer and pre-employment, they need to take a urinalysis. If this is an outside clinic, right? A lot of times they send you to a clinic, you maybe you're on certain prescriptions, and so you offer that to the clinic that's doing the urinalysis. At that time, if you were to bring in your prescription for methadone or Suboxone or whatever the case is, at that time, shouldn't it stop there? Since you have a prescription, why would that information be shared with an employer after that fact?
Definitely. So I'll probably have to look into this. Again, I apologize that I'm not a legal individual or an employment rights full-on expert, but I think also there could be, I'll definitely look into that. That's a very good question. I know that a lot of times employers contract to say all employees have to be screened with a certain panel. So my only concern is if a client brought that up with a drug testing company, would the drug testing company know enough about recovery and treatment to say, to make a decision that would be not adhering to the contract that they might have with an employer? But I agree. I'm willing to look into this, and I will promise that I will look up that question. So if you could please submit that one to Dawn in the webinar, so that way I can remember to answer it. I'll definitely try and find a solid answer for you. And I apologize for not having one now.
No apologies. That's just been a burning question for me for a while, and I definitely would like to be able to share if they're protected from that information going any farther. But thanks again, Jessica, for presenting today.
Cool.
Thank you so much, Jessica.
Right.
We're going to close your piece of things at this point in time so that you're able to make it to your next activity. And then we have
Awesome.
one of my colleagues who's going to present some information. So thank you once again. Have a marvelous day,
All right.
Jessica. For the rest of you
Thanks,
on the
everybody.
phone,
Thank you.
we have some additional information. Matt Christie from the Healthcare Authority is going to share some information with you at this point in time. Matt, are you online and available?
I am online. Can you hear me?
Yes, I can hear you.
Wonderful. So this is Matt Christie with Healthcare Authority, and I am the Foundational Community Supports Program Manager. And I just have a quick, brief announcement and plug for an upcoming RFP that we hope to be releasing in the month of October, so very soon. This is a great opportunity for SUD treatment agencies who are interested in delivering and developing supported employment services to receive seed funds of up to $20,000. And these are seed funds to help launch, again, supported employment services following the individual placement and support evidence-based practice, evidence-based model. There will be a total of 15 grants awarded, so please sign up if you are an SUD treatment agency. Sign up for WEBS. Keep an eye out for this upcoming RFP.
Wonderful. Lisa, did you have anything to add to that? I believe you're still.
Well, only thing I would say is we've worked across Washington, working with a lot of behavioral health agencies that provide substance use disorder treatment, and there has been some great successes in integrating IPS employment specialists and their teams into other substance use disorder treatment teams, and we hope to expand that. The priority for this seed money would be to standalone SUD agencies, but it doesn't mean it won't extend out. It will just depend on the RFPs and who's requesting it or not.
Okay.
But please put that in, if you know of agencies or if you are an agency that provides these services, be looking for it.
And Lisa and Matt, are you prepared to field some questions if people have some general questions about the seed grants? Or is it too new for that to be the case?
It is pretty new, and I don't have much more information than what Lisa and I shared just now. So
okay.
I think, again, it's just more of an announcement that this will be coming up soon, and then there will be, as with any RFP, the opportunity for public questions.
Good deal. All right. Thank you so much.
Yeah, thanks, Don, for the opportunity.
So that being the case, and the primary presenter having had to leave due to other duties today, we will be ending this session early, as was mentioned. And if anyone has difficulties finding my contact information, I will send out a reminder to the group that registered that we're seeking the questions that you might have so that you can respond back with those questions. We'll compile them and send them out along with the recording and with the slides. It may take a couple of weeks to do that. We want to give Jessica the chance to research any questions that come in that she doesn't have an immediate answer for. So be watching for that. Thank you so much for your attendance today. I appreciate the fact that you've been patient with us through some of the technical difficulties, and we'll look forward to seeing you next month at the Topical Employment webinar, which is going to be on social determinants of health on October 17th. Do please sign up. Thank you so much and have a good day.